Welcome to part 4 of fluid and electrolyte balance. Calcium is the most abundant electrolyte in the body. The normal serum calcium levels are 8.6 to 10.2 milligrams per deciliter, and calcium can be bound to albumin, bound to anions, and can be free floating. The free floating calcium is called ionized calcium, and it's the most active form of calcium. When we see just calcium on a lab result, it's the total calcium, so it's all of those sources added together. To get a true idea of what the free calcium is, we draw an ionized calcium level. The normal ionized calcium level is 4.6 to 5.3 milligrams per deciliter. Calcium has a big role in blood coagulation and nerve impulse transmission. It helps muscles contract and relax. It also is a major component of our bones and teeth. Calcium is absorbed from our food, and it can only be in the presence of normal gastric acidity, and vitamin D is required for absorption. Sources of calcium include milk and milk products, beans, and green leafy vegetables. Calcium is primarily excreted by the GI tract in our feces and excreted in lesser amounts by the kidneys. It's regulated by the parathyroid hormone and calcitonin. And when serum calcium levels are low, the body will move calcium out of the bones and increase GI and kidney reabsorption. Calcium also needs vitamin D to be absorbed from the GI tract. Interestingly, there's an inverse relationship between phosphate and calcium. So if the calcium level is high, phosphate is low, and if phosphate's high, calcium is low. And when I think of calcium, I think of muscles and nerves. Hypocalcemia is defined as serum calcium less than 8.6 milligrams per deciliter, but we have to look at the albumin level as well. We should be drawing an ionized calcium level if we think the calcium level truly is low, but it's not always done. Hypocalcemia is caused by hypoparathyroidism, inadequate calcium intake, malabsorption, osteoporosis, pancreatitis, alkalosis, transfusion of citrated blood, kidney injuries, and certain medications. Anything that affects the neck, such as neck trauma, surgery to the thyroid and/or parathyroid glands, should make everyone pay special attention to the calcium levels. When our thyroid or parathyroid glands get irritated, they like to not control calcium. Low calcium levels allow sodium to move into the cells, which increases nerve excitability and causes sustained muscle contractions, which is called tetany. So the symptoms of hypocalcemia include tetany, hyperactive deep-tended reflexes. One of those is called Trousseau sign. One is the Chekhov sign. Seizures, circumoral numbness, which is an early sign of numbness around the mouth. Paresthesias, dyspnea, laryngospasm, abnormal blood clotting, and anxiety. Trousseau sign is when we pump up a blood pressure cuff on their arm and their hand spasms downward and their fingers are pointing. So see the picture where it says Trousseau sign. The Chekhov sign is when we tap on the side of the person's facial nerve and their facial muscles twitch. And both of these signs are indicative of hypocalcemia. Managing hypocalcemia involves replacing the calcium either orally or IV. You need to make sure that the patient has adequate vitamin D, and we need to start seizure precautions to make sure they don't hurt themselves if they have a seizure. If they have hypocalcemia due to osteoporosis, we need to help them not lose so much bone. So exercise and diet and even osteoporosis medications to slow the osteoporosis will help. If the hypocalcemia is related to neck trauma or surgery, usually oral replacement of calcium started the day after surgery is enough to prevent severe symptoms. And the oral calcium we give is like a Tums. It's calcium carbonate. We just give them some Tums. Next, we have hypercalcemia, which is defined as serum calcium levels higher than 10.2 milligrams per deciliter. Hypercalcemia is usually caused by cancer that affects the bones, causing the bones to break down, releasing calcium into the blood, which is about a third of the cases. Or it can be caused by hyperparathyroidism, which is about 2/3 of the cases. Bone loss from lack of activity and some medications like vitamin D, calcium supplements, diuretics, and lithium can also cause hypercalcemia, but it's not as common as cancer and hyperparathyroidism. Usually people with milder to moderate hypercalcemia have no symptoms, but when the levels get too high, like above 15, the person can go into a crisis situation that can become life-threatening. The symptoms of hypercalcemia include polyuria, thirst, muscle weakness, intractable nausea and vomiting, abdominal cramps, severe constipation or diarrhea, peptic ulcers, bone pain, cardiac dysrhythmias, confusion, lethargy, and slurred speech. We have a saying that warm milk makes you sleepy because milk has calcium, and warm milk makes you sleepy. So high calcium levels are going to make you sleepy and weak and depress your reflexes. The management of hypercalcemia is to decrease the calcium level and stop the cause of high calcium. If it's related to bone cancer, we need to treat the cancer. If it's related to hyperparathyroidism, we may need to remove the thyroid and parathyroid glands. And if it's related to medication, we need to stop the medication. To lower the calcium level, we can administer IV fluids to help dilute the blood to lower the calcium and increase urination, therefore kidney excretion of the calcium. We can give IV phosphate to lower the calcium, because remember, calcium and phosphate have that inverse relationship. We can also give furosemide to cause diuresis and make the person excrete the calcium in the excess urine. If the patient can't tolerate these treatments, we can give calcitonin, although calcitonin has a high risk of allergies. Nursing care should include mobility to help bone resorption of calcium, encouraging fluids to help excretion, and teaching about diet changes, especially to help prevent constipation that will probably occur. Next, we have magnesium. Normal magnesium levels are 1.3 to 2.3 milligrams per deciliter, but like calcium, a third of magnesium is bound to protein. The remaining 2/3 are free floating, so when we do evaluate someone for magnesium issues, we need to be mindful of their albumin levels. Magnesium does have an ionized version like calcium does. However, I've never seen it drawn, and magnesium was incredibly important for my patient population. That doesn't mean it's not done, it just means I haven't seen it. Magnesium is an activator for many intracellular enzyme systems and plays a role in the metabolism of carbs and proteins. Magnesium also plays a role in neuromuscular function and acts on the cardiovascular system, producing vasodilation and helps cardiac conduction. Our body absorbs magnesium through the GI tract from green leafy vegetables, nuts, seafood, whole grains, peas, and beans. Magnesium is eliminated by the kidneys, especially if a person's receiving loop diuretics. The body regulates the absorption and elimination by the parathyroid hormone. And when I think of magnesium, I think of the heart and neuromuscular. Hypomagnesemia is a low serum magnesium level, less than 1.3 milligrams per deciliter. It's frequently associated with hypokalemia and hypocalcemia. Because it's bound to albumin, we need to evaluate our albumin levels when we're evaluating our patient for hypomagnesemia. The total magnesium count may be low if the albumin level is low, but if we looked at ionized magnesium, the levels might actually be normal. Hypomagnesemia is caused by alcohol withdrawal, GI losses from diarrhea, enteral or parenteral feedings that are deficient in magnesium, medications like diuretics, and rapid administration of citrated blood products. The symptoms we may see include the Chekhov and Trousseau signs, like we see with calcium, mental status changes, depressed mood, psychosis, neuromuscular irritability, insomnia, confusion, muscle weakness, tremors, and lethal cardiac dysrhythmias. Magnesium is essential for the sodium-potassium pump to work, so if we have low levels of magnesium, we're going to have major effects on our intracellular influx of potassium, which is going to cause a lethal cardiac dysrhythmia. Hypomagnesemia also makes the person more susceptible to digitoxicity, just like potassium. Mild hypomagnesemia can be corrected orally by pills or by diet changes. If needed, we can give magnesium IV, and if we do give it IV, we have to monitor vital signs because of the major correlation between magnesium and the heart. We also have to closely monitor the urine output to make sure the body is able to excrete any excess magnesium they may receive if we give it IV. If the patient has any kidney issues, we may cause hypermagnesemia by accident, and we didn't make sure the excess can be excreted. We also need to watch our patient for seizures and possibly do seizure precautions. We should also have our patient on a heart monitor, as hypomagnesemia has potential life-threatening cardiac dysrhythmias. We also need to teach our patient how to get more magnesium in their diet so this doesn't happen again. Hypermagnesemia is defined as a serum magnesium level greater than 2.6 milligrams per deciliter. Hypermagnesemia is a rare electrolyte imbalance as the kidneys normally filter out excessive magnesium. If it does occur, it's usually due to kidney disorders, diabetic ketoacidosis, excessive administration of magnesium, and extensive soft tissue injuries where the cells have died and released their intracellular contents. We may also see high magnesium levels if the blood we sent to the lab has hemolyzed or clotted before the blood was analyzed. The symptoms of hypermagnesemia include hypoactive deep tendon reflexes, nausea, vomiting, weakness, lethargy, drowsiness, muscle weakness, depressed respirations, EKG changes, dysrhythmias, coma, and cardiac arrest. Managing hypermagnesemia will depend on how high the level is and how symptomatic the person is. We can give IV calcium for very high levels, and the calcium may temporarily reverse some of the symptoms, especially the symptom of respiratory depression. If respiratory depression is severe, we may need to artificially breathe for the patient. If the kidneys are damaged and that's what's causing the hypermagnesemia, we may need to do dialysis to remove the excess magnesium. If kidneys are functioning, we can give loop diuretics to make the person urinate out the magnesium. We need to avoid medications that contain magnesium and teach the patient to limit their magnesium-containing foods and over-the-counter medications. In addition, we have to monitor the patient for changes in level of consciousness, breathing, and deep tendon reflexes. Phosphate is a major intracellular fluid ion. The normal serum phosphate level is 2.5 to 4.5 milligrams per deciliter. Most phosphorus is found in the bones. Phosphorus has a major role in acid-base balance as a hydrogen buffer in intracellular fluid and extracellular fluid. Phosphate also promotes energy storage of carbs, protein, and fat metabolism and helps form bone, teeth, muscles, and red blood cells. We get phosphate from ingesting animal products, but absorption is diminished by concurrent ingestion of calcium, magnesium, and aluminum, so we need to educate our patients not to take phosphorus supplements with other supplements. Phosphate levels are regulated by our parathyroid hormone and activated by vitamin D. It's eliminated through our GI tract and our kidneys, and it has an inverse relationship to calcium. So if calcium is high, phosphate is low, and if phosphate is high, calcium is low. When I think of phosphate, I think of bones, teeth, and ATP. Hypophosphatemia is defined as serum phosphate levels less than 2.5 milligrams per deciliter. Hypophosphatemia can be caused by many things, including alcoholism, feeding patients after starvation, heat stroke, respiratory alkalosis, hyperventilation, diabetic ketoacidosis, hepatic encephalopathy, major burns, hyperparathyroidism, low magnesium, low potassium, diarrhea, vitamin D deficiency, and use of diuretics and antacids. The symptoms of hypophosphatemia may include slurred speech, dysphagia, irritability, confusion, muscle weakness, tissue hypoxia, muscle and bone pain, increased susceptibility to infection, confusion, seizures, and coma. Prevention is the best way to treat hypophosphatemia in people who are at risk. We can replace phosphate orally or IV, but IV is normally only given when phosphate levels are less than 1. To treat orally, we encourage foods that are high in phosphate, which includes milk, meat, beans, nuts, fish, and poultry. If we have a malnourished patient, we want to start by slowly feeding them. We also need to monitor our vitamin D and calcium levels when we have a patient with hypophosphatemia because of that inverse relationship. Hyperphosphatemia is phosphate levels above 4.5 milligrams per deciliter. It occurs in people with kidney issues, excessive phosphorus intake orally or IV, excessive vitamin D intake, acidosis, hypoparathyroidism, or chemotherapy. There may not be many symptoms, and the ones we do see are usually associated with the hypocalcemia. The person may develop soft tissue calcifications. X-rays may show abnormal bone development. We may see hyperreflexia of deep tendons, anorexia, muscle weakness, decreased mental status, and cardiac dysrhythmias. Managing hyperphosphatemia really revolves around treating and preventing the underlying cause. There are medications we can give orally to lower the phosphate levels, which are usually calcium-based medications like antacids. We can give loop diuretics to help the body excrete fluid and phosphate, and we can use dialysis if the kidneys are not functioning. We need to educate our patients to avoid foods that are high in phosphorus, and because of the inverse relationship with calcium, we need to monitor our calcium levels and monitor for signs of hypocalcemia. And this is the end of fluid and electrolytes.